Are we live now?
Sir, we are live on, I think. Ranjit sir on.
Yes, we are just live on YouTube. Just a sec. So we are live on YouTube as well as live on Zoom. This is Ranjit Sahu, Marketing Head with Waterputsam. Welcome you all. This live webinar on hypertensive disorders of pregnancy. With this, I hand over the session to ma'am to take it forward. Over to you.
Yeah, thank you so much. Thank you. And welcome each one on this live webinar on hypertensive disorders of pregnancy. We are doing this web series number 5. This is a Indo-International series in association with RCOG India Liaison Group. So this is a wonderful, wonderful initiative that has been taken, and the series has been a really very, very successful. Whoever the viewers, the feedbacks that we have got are wonderful, because this is something unique that has been brought, because we take our Indian perspective and the international perspective, and then we mix and match, and from the evidences we understand what exactly we should be doing. So this is we have our international coordinator for this. We have Dr. Jyotsna Pundir. She is a specialist in fertility assisted conception, London, but I am afraid she would not be able to join us today. So without much ado, I would now invite our convener, Dr. Lakshmi Srikhande ma'am, and to introduce about the web series, and then introduce our another convener, Dr. Padma. Over to you, Lakshmi ma'am. Lakshmi, yes. Okay. Yeah. Before that, I'll give you a brief description of Dr. Lakshmi. As we can see on the screen, she is chairperson-elect ICOG. She is National Corresponding Editor, Journal of Obs and Gynae India, National Corresponding Secretary, Association of Medical Women India. She is also founder, patron, and president of ISOPA Vidarbha, Chapter 2019-21. She is chairperson, IMS Education Committee, president of Association of Medical Women Nagpur, and has also received Nagpur Ratan Award by them. So we would cut it short now, and yes, over to Lakshmi ma'am.
Yes, thank you, Jyoti. Thank you so much. And as Dr. Jyoti has already highlighted, that this is our series 5, totally focused on hypertensive disorders in pregnancy. Dr. Jyotsna Pundir is our international coordinator, and she has sent her regrets and regards for this web series 5. Our international convener for today's web series is Dr. Padma. Padma, you are welcome. And our international faculties, Dr. Abhi and Dr. Fran. I welcome you all three to India. I also welcome our esteemed chairpersons, Dr. Ajay, Dr. Rashmi, Dr. S.P. Jasavar, and Dr. Sudha Sharma. Along with that, I also welcome all the esteemed panelists, Dr. Priyankur, Dr. Ritu, Dr. Pushpa, Dr. Charmila, and Dr. Arun Barua. In this today's web series, we have 2 guest lectures by Dr. Padma and Dr. Abhi on chronic hypertension and severe hypertension, and then case-based panel discussion will be moderated by Dr. Fran. So without wasting much time, I once again welcome all my esteemed faculties and all the dear audience who are there, who have joined us for these deliberations on hypertensive disorders in pregnancy. So I hand over back to Dr. Jyoti for further scientific proceedings.
Thank you so much, Lakshmi ma'am. And I invite now our chairpersons for the first session. So Dr. Sushma Verma, our national coordinator, also would be joining us a little late. So we would move on first to our chairpersons for this session. The session is on chronic hypertension and mild PET. And for that, we have Dr. Ajay Mane, who is member of NIMC, that is National Inspection and Monitoring Committee, PCP&DT Wing, Government of India. He has been a medical legal consultant for the last 18 years and has been giving free of cost advice. So that is a commendable job that Dr. Ajay Mane has been doing over so many years. Dr. Mane is a chairperson official AMOG's website and also a chairperson of the Sexual Medicine Committee FOGSI in 2014. He was also the chairperson of Adolescent Health Committee in 14 and 16 and is a joint secretary of AMOGS, that is Maharashtra State Association of Obs and Gynae. Sir is past president Aurangabad Obs and Gynae Society, national trainer for FOGSI Adolescent, has publications, 9 national, 4 international, has authored various topics in FOGSI focus, and has been health advisor to Sports Authority of India. So I welcome Dr. Mane sir, and the second chairperson that we have, another very beautiful and a very academic person. We have Dr. Rashmi Vyas here, who is also an ex-council member Society of Fetal Medicine UP chapter, and she is organizing chairperson of North Zone Yuva FOGSI 2019 and has published many articles, journals, and received appreciation awards for her exemplary work during the Bhopal gas tragedy. So over to the chairpersons, and I request Dr. Mane sir to introduce our convener for this webinar, Dr. Padma.
Yeah,
and
thank you. Thank you, Jyoti ma'am. At the outset, I must convey my gratitude to Lakshmi ma'am, Jyoti ma'am, and Padma ma'am, and my dear friend Josna from London, whose umbilical cord is still attached to India, and Dr. Sushma ma'am. Dr. Padma Idrapalli, she is MD FRCOG, BSc CFE RCOG accreditation in colposcopy, PGC medical ultrasound. She is a consultant obstetrician and gynecologist, lead colposcopist since 2006. She is working in University Hospitals, Dorset, NHS National Health Scheme, Foundation Trust, Bournemouth, UK. Then honorary course supervisor and faculty member, gynecological ultrasound. Then AECC University College, School of Radiology, Bournemouth. And her special interests are colposcopy, maternal medicine, gynecological ultrasounds, medical education, and quality improvement projects. She is very expert in the topic which is given to her, that is chronic hypertension and mild PET. Nowadays we know that the PET and everything is due to calcium deficiency, D3 deficiency, nutritional deficiencies and whatnot. And for that we invite Dr. Padma to elaborate everything in details. Welcome, ma'am. Dr. Padma.
Thank you. Thank you so much for the kind words and introduction. So I'll move on straight to my talk. Just give me a second to put it on slideshow. As I said, I'm going to talk about less acute or chronic hypertension and less severe preeclampsia, and my colleagues pick up from there. So PIH worldwide affects 10% of pregnant women. This is the milder end of the spectrum. So out of that, only 2 to 3% actually develop preeclampsia, that is with proteinuria. Severe preeclampsia only affects 0.5%. It's a small proportion of them. 1% have pre-existing hypertension in pregnancy. It could be primary hypertension or it could be secondary hypertension to kidney disease. Eclampsia, however, in the developed countries, because of introduction of various screening prediction tools and preventative measures, has gone down to 1 in 2,000. That's the UK statistic. But in developing countries, it can be as high as 1 in 100, and it's variable to more developing nations to 1 in 1,700. So what are the implications of preeclampsia or hypertension? The worst thing is maternal death. So in UK, we have the good fortune of many decades of confidential inquiries into maternal death. Every 3-year block of maternal deaths nationwide are analyzed by an organization called Embrace. You can see their summary on the right-hand side here. So you can see that in the earlier decades, 2003 to 5, only 18 women, out of about 2.5 million women who have pregnancies, had died of preeclampsia. Whereas a decade and a half later, 2015 to 2017, 5 women only died, contributing to, if you see at the bottom of this chart, preeclampsia, 2% of all maternal deaths. You can see the strides UK and other developed countries have made in decreasing the mortality from preeclampsia. This is in contrast to the maternal mortality rate of 9.2 per 100,000. And to give a contrast, in India, the maternal mortality as it stands for the similar period is 113 per 100,000 live births. And I dug a little bit deeper to find out what is the leading cause of maternal death. And there are some CLIP studies, which I found are the most accurate figures for the Southeast Asia, including Pakistan, and also they clubbed Mozambique in this. And they found that the top 3 causes in a similar period was of maternal death, that is, was hemorrhage, non-obstetric causes, followed by hypertension. But exactly what proportion of these deaths are due to hypertension, I couldn't get a figure. But setting it aside, 1/3 of all severe obstetric morbidity is because of preeclampsia. A quarter of hospital admissions, a quarter of low birth weight infants, 15% of premature infants, 1 in 5 stillbirths, they're all due to preeclampsia. And so there is also quite a lot of workload. So example, extra visits by the community midwives, if you have a system like that, or hospital admissions, or hospital visits, consultant clinic visits. So that is quite a lot of cost and expense as well. In addition, there is emerging evidence that developing preeclampsia has implications for your future cardiovascular health. And therefore, it is important that we understand hypertension and definitions and how we manage it. So it can be divided into pre-existing hypertension, i.e. either recognized at the beginning of the pregnancy before 20 weeks, or you had it before and you knew about it, or gestational hypertension with onset after 20 weeks in a previously normotensive non-proteinuric individual. So if it's a pre-existing hypertension, if you have excluded all other causes, it becomes primary or essential hypertension. And if it is due to a renal condition or something like that, or other causes, it becomes secondary hypertension. So either primary or secondary hypertension has the problem, of course, in that if it is not well controlled, it could lead to superimposed preeclampsia or eclampsia. On the right-hand side, you have the gestational variety, where it could just be hypertension, pregnancy-induced hypertension without any proteinuria, or it could just be significant proteinuria without hypertension, or it could be both together, which is the preeclampsia, so proteinuric hypertension. And of course, you add the fits or seizures, and that becomes eclampsia. So most classifications use both systolic blood pressure of more than 140 and diastolic blood pressure of more than 90 on 2 occasions, at least 4 to 6 hours interval. But some use just diastolic blood pressures. And if they had 110 or more diastolic blood pressure, even once, that could constitute to diagnosis of hypertension. But you also have to have significant proteinuria if we were to call it preeclampsia. That's more than 300 milligrams in 24 hours of urine, or we use what is called as a snapshot PCR test, protein creatinine ratio, which I will elaborate a little bit later on in the slides. So essential hypertension. Now this is important because if you're non-pregnant, every 2 millimeter increase in hypertension is associated with 7% increased mortality from ischemic heart disease or strokes. The prevalence is more in Afro-Caribbean race. As you get older, you tend to get it. The older ladies tend to get systolic hypertension, more younger varieties get diastolic hypertension. About 15 to 40% can have superimposed preeclampsia. Now, secondary hypertension, I won't elaborate into various conditions, but in my practice, in the last 15, 20 years of seeing chronic hypertension in my maternal medicine clinic, I would say the top is renal, glomerulonephritis, IgA nephropathy, on a rare occasion, polycystic kidney disease. I haven't seen the rest of them, phacocytoma, etc. So I will just jump and go to the next slide. Now, the complications here given for chronic hypertension are exactly the same if you had preeclampsia as well, so I don't need to duplicate it in future slides. Of course, apart from maternal death, there is this aspect of hypertension becoming uncontrollable, could lead to CVS, which is stroke. So rare cases in chronic hypertension, it could lead to myocardial infarction, could lead to pulmonary edema or ARDS, renal failure. Pregnancy-wise, you can have abruption, iatrogenic premature cesarean deliveries, postpartum hemorrhage, etc. On the fetal side, you can have IUGR or growth restriction, preterm delivery, iatrogenic or otherwise, stillbirths, and neonatal deaths. So I'll move on to the Etio pathogenesis of preeclampsia. Now, according to the ACOG task for 2013, they summarize it very nicely, saying that preeclampsia is a multi-system disorder, and it is the root cause is placenta, 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 and the cure is to deliver placenta. So what happens in the placenta? So there could be genetic predisposition. So you can have a sister who with preeclampsia that increases the risk to 40% in your case. If you have a mother, 25%. So there may be a genetic predisposition. Similarly, immunological mechanisms in alteration in trophoblast function has also been proposed. So what happens in people who are destined to develop preeclampsia? So on the left-hand side, you see a non-pregnant vasculature. So you have the arcuate vessels dividing into radial arteries and then spiral arteries. And this is the endometrium, or in pregnancy, it becomes the decidua. And there is the placenta, okay? So this is a normal pregnant woman where you can see the trophoblast invades in two phases, at 12 weeks and 16 weeks gestation. So it basically invades into the spiral vessels in the decidua, and syncytioblast is replacing the endothelium, vascular endothelium. It's also growing into the intima, elastic, lamina, and then media, and the fibrous tissue is laid down. So basically, and then that extends later on in 16 weeks, even into the myometry or decidual junction spiral vessels. So what it is basically doing is building up high capacitance, so big capacity lumen vessels with least constrictory capacity. So they're not responding to pressure agents like sodium or catecholamines, etc. So they remain open even in diastole so that the baby gets flow, not just heart systole, but also during diastole. So it is preparing for feeding the baby properly. Whereas in preeclampsia, those waves of invasion and vascular remodeling may not happen adequately, or it may not happen at all, which means you are left with narrow, low capacitance vessels which respond to pressure agents very easily. And that leads to placental ischemia, and that leads to release of what are called as toxic compounds previously, which gave rise to the name of preeclamptic toxemia, but now they are called as mediators, such as antagonist to vascular growth factors, if you like. But the end result is that they are released into your systemic circulation, and even in the placenta, the endothelium is damaged. It leads to further narrowing of the blood vessels in people who develop preeclampsia, leading to placental ischemia, IUGR, etc., and end organ damage, even if it is temporary in preeclampsia. Now, this is a microscopic example of what happens in placenta when you develop preeclampsia. It's called acute atherosis. Basically, the cells are damaged, vascular endothelium, they become ghost cells, foam cells, and there is deposition of amorphous material. So the other target organs are kidney. This is called glomerular endotheliosis, where the glomeruli, the endothelium, gets swollen and it blocks the lumen, and inter cell, there is leakage, capillary leakage basically into the kidney. And so you filter a lot of protein out, which is not normal. And the same thing can happen in the lungs, leading to pulmonary edema. Same thing can happen in the brain, etc. So cerebral edema, retinal changes, etc., etc. So what are the risk factors? So I won't read out all these risk factors. The risk factors A are moderate risk factors, whereas pregnancy, if you've not had a baby for more than 10 years, 40 years age or more, 35 BMI, family history, proteinuria, etc., booking. If you have 2 or more risk factors, you need to go on low dose aspirin. And I will get into low dose aspirin doses, etc., in future slides. The slide B shows high risk factors. So if you had previous preeclampsia, multiple pregnancy, or pre-existing medical conditions as listed, then again, even one condition, you have to be given low dose aspirin. That's our nice guidance. So what is the role of other screening tools, for example? Now, uterine artery Dopplers have been touted by various studies, but I would say that they are not very good as a screening tool in the general population, or even in high-risk individuals, because they catch less than 50% of severe preeclampsia or IUGRs. So the difference is this is normal uterine artery Doppler where there is diastolic flow. This is not seen in non-pregnant individuals. In pregnancy, you get diastolic flow. Whereas in preeclamptic destined women or IUGR destined women, you get a pre-diastolic notch, meaning the diastolic flow, actually, if you look at the amplitude of this Doppler, also it's much lower. So that can predict, but it's not widely used as a tool. So how do you prevent? So I have already told you the risk factors and how you can prevent with aspirin, but knowing who has increased risk is also important. So if you had gestational hypertension, your risk is 1 in 7. If you had any kind of preeclampsia, it becomes 1 in 5. If you had previous delivery under 34 weeks because of severe preeclampsia or other complications, then in 1 in 4. If you had a delivery under 28 weeks, it's so severe that your risk is 1 in 2. So what about aspirin? Why do we use aspirin? So aspirin is cyclooxygenase inhibitor. So in the platelets, it inhibits thromboxane A2, which is a vasoconstrictor and platelet aggregator. So if we gave in low doses, it preferentially inhibits thromboxane A2, but doesn't touch the prostacyclin, which is the vasodilatory prostaglandin. So, and that's why it is used in lower doses. Cochrane review of all the trials available in 2019 revealed that if you gave aspirin in lower doses, something between 75 and 100, you can decrease the incidence of preeclampsia by 18%, but the sequelae, preterm births, neonatal deaths, SGAs, etc., are decreased much more. But there is no increase in bleeds, antepartum bleeds or postpartum bleeds. That's also important. But when they did a subgroup analysis, they found that if you give 150, actually you can also prevent gestational hypertension, which led to the recommendation from NICE that you can actually increase it to 150 milligrams. You start it at 12 weeks and till term, but if you've delayed it at least under 28 weeks, it does have some benefit. So how do you monitor for blood pressure? So the regular monitoring in the bottom slide is for all low risk women. They're not at risk of hypertension. But if you had risk factors, then NICE recommends more frequent monitoring of blood pressure. So 3 weekly between 24 and 32 weeks and 2 weekly over 32 weeks. So this is implemented for us in the UK by the community midwives. So how do we do that without bringing them to the hospital and increasing the workload? So I introduced a program called Florence, which is a patient self-BP monitoring aided by telemonitoring by a text message-based system called Florence. Now, after the initial trial, which was successful, we changed to an app-based system called Reassure, which is even simpler to use and it is less costly. Now, this was all based on ACOG guidance that all PIH, all non-proteinuric hypertensives, chronic hypertensions, postnatal hypertension, as long as there is no biochemical derangement or end-organ failure like renal failure and things, they can be monitored with this self-monitoring because the blood pressures measured by the women tend to be lower. And actually, by using that, you can get better control, or not to mention the benefits on the workload. Now, this is a slide of our experience with Florence. As you can see, a 1-year experience. This was an experimental thing. 131 women. I'm proud to say we were the second unit in the UK to adapt it from the Northern unit from Professor Kim Hin Shaw. We had 130 women. Average spend time on flow was 5 weeks. And only 15 patients actually needed extra input, hospital admissions, etc. Throughout the year, 100% liked the system and the workload was reduced and we saved quite a lot of money. Now with Reassure, we are doing even better. So basically we give pregnancy validated blood pressure machines to the women, dipsticks. They do it at home, prompted by an app which is downloaded onto their mobile phones. And we have a central control in the hospital by the midwives who the automated messages are sent to the women on the days they have to send the blood pressure. And they also check the alerts, check about symptoms. And the system has the ability to recognize what is a severe hypertension. So because it's divided into amber, green, and red, and the messages will tell them either to go immediately to the hospital, call an ambulance, or go to endo or contact the midwife. So there is inherent fail-safe mechanism in it, and it is working very well. So you could use that instead of doctors or midwives monitoring it. So how do they present? So it can be completely asymptomatic. You check the blood pressure, you find it high, dipstick, proteinuria, but they can have headaches, visual disturbances, epigastric pain, vomiting, or one of the complications. They might present with complications. So for us, we have a community system. So this is the guidelines for precog, so community guideline from RCOG. So basically, sorry, can you hear?
Yes, yes, Padma.
Sorry, the microphone has changed and I wasn't sure whether you're hearing.
No,
Good.
no, now it is loud and clear. We are happy with this microphone.
Good, excellent. So basically, if you didn't have proteinuria, if it is a very high blood pressure, same day, please send same day. Systolics of 160 should give you the flashing light signs, literally flashing lights, excuse the pun, of CVA, send them to the hospital. Diastolic blood pressures, again, high blood pressures, even if they don't have proteinuria. If they're lower blood pressures, but with symptoms also same day. If they don't have symptoms and the lower blood pressures, you can assess them in 48 hours in the hospital. If they have proteinuria, you have a lower threshold to send them for immediate, referral to hospital. If you have proteinuria, 1+ or more is significant, but you can repeat it in a week. And if it's 2+, 48 hours, and if they have symptoms, worry about blood pressure straight away. So if you just have symptoms, epigastric pain is significant. If they have high blood pressure, of course, you send them the same day. Otherwise, you monitor. So this is under quite an old picture, antenatal day assessment we have. So this is not a ward. We see them as an outpatient and assess these patients where they arrive from the community. So we do baseline blood tests, mainly for hemoglobin and platelets called full blood count. We do kidney function, urea and creatinine and electrolytes, liver function test, ALT. Protein creatinine ratio is a snapshot test, not the 24-hour collection. So it is equates to the 300 milligram. So if it's 30 or more, it is significant proteinuria. Clotting tests are only done if the platelets are low. We obviously measure the baby's or check the baby's health by continuous Ctg cardiotopogram and a baseline ultrasound scan to check the growth, and then repeat it 2 weekly or 4 weekly, depending on the initial presentation. So the other thing we use here is something called preeclampsia ratio. This is a test which is recently recommended by NICE, but we have been using it for a fair few years now. It basically measures a ratio of soluble FMS-like tyrosine kinase, like a mediator, if you like, in the blood, in the whole blood, versus the placental growth factor levels. So the SFLT1 is raised in women who are developing impending preeclampsia. So this is used if the ratio is under 38, the prognosis study has found that it has a high negative predictive value. So you can rule out preeclampsia with a high confidence. Similarly, the raising levels beyond 85 also have been found to be useful in diagnosing preeclampsia or ruling in. Currently, NICE says ruling out, use it by all means, ruling in, a little bit more careful. So we use this. So in women between, say, 20 to 35 weeks, if you are not sure, then you use this ratio. And if it's under 38, it has the negative predictive value of excluding preeclampsia within the 7 days after the attendance. You rarely repeat it, but you could repeat it after 2 weeks. It has no practical use after 35 weeks. And as you can see, as the ratio increases, there may be utility in ruling in preeclampsia. So this is again the SFLT ratio and what happens. So severe preeclampsia, adverse pregnancy outcomes increase. So the NICE is also recommending some of the algorithms or risk prediction models called full PS, and this is something called PrEP-S. So basically, you put in all the data about gestational age, blood pressure, what medication they are on, magnesium sulfate, etc., etc. And this is a logistic regression model which spits out a risk within the 48 hours of what is the risk of preterm delivery or eclampsia risk or fetal risk or adverse outcome risk, etc. So, but the websites say that it still needs to be validated in clinical practice. So I don't think we are not using it locally. I'm not sure whether any other unit is using it in the UK. So how do you treat? Now the treatment is important, obviously, but it is important to know when actually to treat and when not to treat and when not to admit. So if they didn't have proteinuria, as a general rule of thumb, unless the hypertension is quite severe, you don't admit them. You might see them on antenatal day assessment. And again, blood pressure targets are 150, 95, that sort of level you treat. Anything lower, you don't need to jump and treat. And that is the recommendation for European Society of Cardiology and in general from NICE also. Because tight regulation is not necessarily good for the baby growth, etc. With regard to the blood test baseline, you don't need to repeat it often. Blood pressure measurements in case of higher blood pressures may be twice a week if they're in patients 4 times a day, otherwise weekly. If you have proteinuria, you tend to be more careful. You might admit them just to watch to see whether they deteriorate. And again, blood pressure targets where you would start treatment would be the same as in the previous slide. If they're in patients, you would do 4 times a day. And the blood pressure monitoring is more frequent when they're discharged. Blood test repetition is also more frequent. So in preeclampsia in particular, there is no change to the underlying process. There is an improvement to all outcomes, maternal death, severe hypertension, eclampsia, etc. But overzealous control, as I said, could cause IGR, etc. So the targets are 135 and 85. There are some trials called CHIPS. I won't go into it in detail. I think maybe going over time. I'm conscious of that. But the main thing is monopharmacy. So don't give too many medications. Try the first one to the maximum dose. We tend to use labetalol as the first choice and nifedipine as the second choice. And I'm aware that Methyl Dopa is a choice in other other parts of the world, but there's nothing wrong with Methyl Dopa. We prefer to avoid ACE inhibitors, A2 blockers like sartans and statins and thiazide diuretics because of the worry about teratogenicity, renal toxicity, IGR, etc. So generally, they're contraindicated in pregnancy. And safety in breastfeeding, well, there are no studies to say it's actually unsafe, so they're not absolute contraindicators. But if you have other more safe medication like nifedipine, etc., we tend to prefer that in a lateral even postpartum. So other things, no bed rest, but you can rest. All these other things other panelists have mentioning absolutely have no role. Magnesium, vitamin E, vitamin C, sildenafil, nitric oxide, all sorts of things, no role. Calcium supplementation in populations with low dietary intake, there is a question mark over that. Low salt diet in chronic hypertension, yeah, good use, but in preeclampsia, it doesn't prevent it. May be helpful, but there is no evidence that actually it makes any difference. So medications, you go to the maximum dose. Labetalol, you have to be wary about severe asthma, heart blocks, and so on. Hydralazine generally tend to be a second line drug. So add it to labetalol or nifedipine, but not on its own, because more than 100 milligram dose per day can cause SLE, lupus erythematosus. So nifedipine, when you're using, one caution is use MR, modified release, not the pure one, which Abby will tell you. We will use it for acute hypertension, not for more long-term control. Okay. Methyl Dopa, we don't tend to use it because postpartum, it can cause drowsiness, depression, and anemia in the baby. Timing of delivery, I will rush through this. Chronic hypertension, it's just expert opinion. If it is completely stable, you can offer induction at 39 weeks, whether they're medicated or non-medicated. But there's no evidence that actually it makes any difference. So the NICE says discuss it with the woman and make a decision based on their wishes. On the other hand, you have preeclampsia, which is treated but it is quite stable. There is no advantage to prolonging the pregnancy beyond 37 weeks because they can only deteriorate into eclampsia and other things. In between, you're guided by what the baby is doing, SGA, is the blood pressure under control, are there any organs affected, etc. So if they're very early, you might consider steroids, especially if you're delivering by C-section under 39 weeks or under 34 weeks, even with vaginal birth. So consideration is given to the complications. Interpartum care. So when they're present in labor, you monitor the blood pressure hourly. These are women who already have hypertension or preeclampsia. If they develop severe hypertension, Abby will talk about this, they go to a HTU area within the labor ward. And we do full blood count and clotting, especially if they are considering epidural. Epidural is a good way to lower their blood pressure because painful labor can aggravate the blood pressure. The common principle is not to give them too many fluid because preloading means that they can develop pulmonary edema. So drink to thirst if they're on oral liquids. Concentrated oxytocin if you think that they're overloaded rather than a dilute drip. Assisted delivery if the blood pressure is very high, and Fran has some examples of these patients. Avoid ergometrin because it can increase the blood pressure, but you have to give it if they have massive PPH. Postpartum hypertension. Now, it can arise de novo. You can have eclamptic seizures de novo. In fact, postpartum eclampsia is more common, so we have to be very careful, especially those who have already got blood pressure. So the first 24 hours to 48 hours is vital. You keep them and observe them. You may even come off the blood pressure medication if the blood pressure is under 140/90. If it's slightly higher, continue. And more frequent monitoring when they go home. 2 weeks later, the GPs may have to see them and adjust the medication. 12 weeks later, if proteinuria persists, they need to be referred to renal physicians because there could be an underlying renal problem. We avoid diuretics because of breast milk reduction, thirst, etc., increased thirst. And you ask the patients to monitor the symptoms and report, especially within the first week. After that, eclampsia is uncommon. So medications, as I said, in general, we continue with levodopa and nifedipine. Tend to be careful about atenolol, especially because it can cause hypoglycemia, although that risk is there with levodopa also. But enalapril is quite a good one. If you need long-term medication, once a day, unless there is kidney damage, acute kidney injury from preeclampsia, is quite a good way to control blood pressure. It's okay with breastfeeding too. But what about postpartum hypertension? So I said this already. So I'll skip this slide. Future risks. So if counseling is important when they are discharged or in the community, we tell them the risk of cardiovascular disease, i.e. developing strokes, hypertension in later life, diabetes and blood pressure, etc. And severe strokes is twice in all people who've had gestational hypertension, particularly high, 8 to 9-fold if they delivered before 34 weeks. Lifestyle modification, like everything else, weight loss, stop smoking, alcohol, exercise, low salt diet, etc., in the interim period. Preconception care, it's important to establish the cause. If it's a primary hypertension, have they excluded secondary causes before? If not, you may have to do all these investigations to make sure that there's no renal or cardiac cause. Adjust antihypertensives to non-teratogenic ones, especially if they're going to embark soon on pregnancy. Evaluate for other methods. So that's it, folks. Thank you.
Hello, everyone. So, Dr. Lakshmi, first, my sincere thanks to you for including me in such a wonderful, prestigious program. And I'm really happy to co-chair with Dr. Ajay Rane, such a wonderful person, and everyone. Regarding this presentation, very crisp and clear presentation. Dr. Padma, you have elaborated each and every point. And importance of early detection, we can't prevent it totally, but at least we can prevent the complications. That is very, very important. And you have elaborated everything, risk prediction. So, and one important aspect which generally is ignored is postpartum. because postpartum generally patient is also relaxed, doctor is also relaxed. Okay, now delivered, baby is fine, mother is fine. Okay, forgot to tell them before discharging that you have to take care of your blood pressure now also. Still you are under, I mean, at least first week is very, very crucial. And importance of early dose, early starting aspirin, because so many times people start aspirin very late. So then there is no use, even though you are giving the dose, whatever dose you are giving. So thank you so much, Dr. Padma. It was excellent. And I think over to Dr. Lakshmi.
Thank you. Thank you.
Simply superb. Padma, you covered all the aspects and gave evidence-based, clear-cut messages to our audience. Hats off to you. Back to Jyoti.
Yeah, thank you so much. Thank you, dear chairpersons, Dr. Mane sir, Dr. Rashmi ma'am, and the speaker. I mean, it was absolutely wonderful. We've received so many comments about your crystal clear talk in the chat box, Dr. Padma, and I think we'll stay. You will be still getting more questions also. So please stay on if possible. So moving on, we have now the management of. The topic would be management of acute and severe hypertension. So for that, we have our chairpersons. We have Dr. Sudha Sharma, who's a former professor, PG, Department of Obs and Gynae, GMC, Jammu, Kashmir. So welcome, ma'am, and welcome to this wonderful webinar that we have. In fact, because of the webinar, we can at least like have you here, right? I mean, Jammu and there Indore and Delhi and everything can be here together on the same platform.
I know, very right.
Yeah, so ma'am is Secretary General IMS. She's Honorary Professor IMA. She's Managing Committee Member PCOS Society of India. She's President Jammu Obs Gynae Society. She was founder President of the Jammu Menopause Society. Editor-in-Chief, Journal of Midlife Health, member editorial board, Journal CEFOG, editor-in-journal, JK Science, Journal of Medical Education and Research, member National Advisory Board and Journal Committee, associate editor. So thoroughly, she is on editorial boards of so many journals. And welcome to this platform as well, ma'am. And ma'am has so many publications and edited 3 books. Then we have another great personality to chair this session. We have Dr. S.P. Jaiswar, ma'am, and she is Professor, Unit Head, Department of Obs and Gynae, KGMU, Lucknow. So she has so many fellowships, awards, and she is so many memberships of all the various societies. Ma'am has gold medal and video of the fellowship award in DM Sharma, Madhu Sharma, gold medal and video presentation, Dr. D. Kuti Oration Award, then Dr. Chandravati Devi Jagannath Singh Prize Award, and Eminence in Research Award. Ma'am has so many awards, trophies. I think.
Thank you so much, Jyoti. Thank you so much.
Yeah, ma'am, thank you for saying. I don't know where to end your CV. So over to the chairpersons, and I would request Dr. Sudha ma'am to introduce our speaker, and then Jaiswal ma'am can conclude the session after the talk. So our speaker, over to the chairpersons, please.
Thank you, Dr. Jyoti, for your kind introduction. So very good evening, everyone. At the beginning, I would like to congratulate, conveners, national and international coordinators for organizing this Indo-International Web Series in association with RCOG, RILG. It's a wonderful thought, Dr. Lakshmi, and wherein we also know the overseas prospects about all these diseases and how to manage. And thank you, Dr. Lakshmi, for making me a part of this invite and inviting me over here. And the topic chosen is so very important. I tell you, hypertensive disorders in pregnancy. It was important decades and decades ago. Important it was when we were UGs and when we were postgraduates. And of course, why important globally? Because it is one of the most important cause of maternal and fetal morbidity and mortality. Classification kept on changing, management kept on changing, but yes, it remains important. So in our times, I don't know whether people are over here during my times or not. Cesarean section, was one of the contraindication in eclampsia of pregnancy. माँ और बच्चे में से एक को बचाना है. We can save either of the two. It was like a filmy dialogue. And look at now how the management has changed over the time and improved maternal mortality and neonatal mortality. But still, lot needs to be done. And to address the topic, we have today with us a very, very eminent international faculty as star speaker, none other than Dr. Abby Langries. She is BM MRCOG. She is consultant obstetrician at University Hospital Dorset. She has special interest in fetal medicine and fetal growth surveillance. She is consultant lead for Antenatal Day Assessment, ATSM holder in advanced labor, ward practice and fetal medicine. I very humbly invite Dr. Abby for her deliberation. Dr. Abby, over to you.
Thank you for such a kind introduction, and thank you for inviting me to present today. I would just share my screen. So my talk today, I've been asked to run through how we can provide some very
slideshow. Abby?
It is on slideshow.
Yeah, make it slideshow.
Yeah, I have.
Full screen. Make it full screen.
I have.
Yeah, make it a full screen. Hit F5.
I'm sorry, on my view, it is on full screen on slideshow.
Okay, because we can't.
So I think when you go, Abby, sometimes I know it doesn't share, but you go into slideshow and start from beginning or something like that at the top.
I'm sorry.
Yeah, you can reshare here.
Yeah. Sometimes it doesn't happen. We've seen that with the.
Are you seeing the full screen now?
No, still it is not in full screen, please. Somebody is there to help me.
Technical team, please mute the others.
So sometimes from laptop, it doesn't work. So sorry, but it's okay to present like that, I think.
I think
Yes, I am on the laptop.
Actually, we
The
saw the
laptops I've
icon
seen
in
it
the,
doesn't work full screen. So just present like that. I think.
yeah.
actually the icon was seen at the end. Actually, you can press on that probably. It's down. It's down. The last. The icon is seen at the last. Slide share. Go down a little bit. Yeah. Click there. It may work.
Are you seeing a full screen?
No, not yet. Just wait for a second. Sometimes it works.
Okay, I'm sorry.
No, that's fine. These are technical issues, technical problems.
Just try clicking once more. I think you need to be a little this thing there. Just click once more. The slide share icon, the slideshow icon, the fourth icon there.
Yeah, I've got it on my view, it is full screen.
Okay,
So,
then
okay, you go ahead.
I think
You please go ahead. Yeah, we can see.
We can see the presentation.
Yeah, please go ahead.
Shall I carry on? Apologies for that. So yes, today I've been asked to talk about the management of acute severe preeclampsia when presenting in our hospitals, and some tips on how we can prevent complications. And so today I'd like to talk through how we can look at the risk factors, the signs and symptoms, and how preeclampsia can be very subtle in its presentation. So it's very important to pay attention to all sort of manner of variation in symptoms. Talk about how we can prevent complications through good management, and to prevent mortality and morbidity in this very high risk group of patients. So as we know, patients will present to our hospitals in a huge range of variable symptoms and signs. And sometimes you do not need to have the whole tick box of symptoms in order for a lady to have severe preeclampsia. And I think this is demonstrated very well in some of the case presentations that Dr. Frown will be presenting next. But just to sort of cover for completeness, usual symptoms are increased peripheral edema, increased facial edema, headache, visual disturbance, which lots of ladies describe as a twinkly light in front of their eyes. And they often have a pressure headache across the front of their head. Sometimes, but in less common circumstances, they'll have epigastric and right upper quadrant pain. And often when preeclampsia is very severe, they will feel agitated and anxious and have a shaking tremor, which I think is not often talked about, but is an important sign and symptom for this group of patients. When you then go on to present them, they will be hyperreflexic with brisk patellar reflexes and have clonus when the foot-heel clonus test is done. They may have a tender right upper quadrant, they will have a high blood pressure, and they of course will have proteinuria. In this circumstance, when a lady is presenting with symptoms and signs of preeclampsia, it's important to establish the level of protein that's within their urine. And we do a spot test, which is called protein creatinine ratio, which is just as sensitive as a 24-hour urine collection, but will obviously give you very quick diagnosis and quantification of the protein in their urine. Bloods, we are particularly looking for platelet count, and a diminishing platelet count will give good indication that this is preeclampsia. And obviously, if it is lowering very quickly, we need to be prepared. They may also have a reducing HB from hemolysis. They may have a raised ALT, and they may have raised creatinine from a renal impairment in this disease. We obviously need to pay attention to baby as well. And so in this circumstance, you're always going to be asking about fetal movements and placing the lady on a CTG to assess fetal well-being. So as it has been shared before with Dr. Padma, we do have, the classification of mild, moderate and severe preeclampsia, with mild category of patients having lower blood pressures and probably being asymptomatic. Moderate patients will have a higher blood pressure of 150 over 100 millimeters of mercury. And they may have some symptoms which are affecting their lifestyle and daily routine, and they will may have some blood derangement. In the severe category, they will have blood pressure of 160 over 110, and they will feel unwell with symptoms that are affecting the way that they're able to conduct their daily habits, and they will most likely have the beginnings of blood derangement. So you may start seeing a mild ALT rise, a mild platelet decreasing count, and this is the beginning at which we need to pay attention and take action. So maternal complications from severe preeclampsia have huge implications, with the leading cause of death in the UK as a complication of preeclampsia being intracranial hemorrhage. And that is because high blood pressure has not been controlled properly. There's also complications of abruption, eclampsia fitting, DIC, and we have a very good case of this being talked about later. HELP syndrome, which is a version of severe preeclampsia where there is hemolysis, elevated liver enzymes and low platelets, which are seen on the blood workup. Renal failure, pulmonary edema, and acute respiratory distress syndrome as a sequelae of pulmonary edema. For the fetus, there's complications of intrauterine growth restriction, as Dr. Padma has alluded to, this is a disease of the placenta, and so baby can be severely affected. There can be oligohydramnios, hypoxia from placental insufficiency, placental abruption, fetal distress, preterm birth, and intrauterine death. So our national recommendations that come from NICE are that women with severe preeclampsia need effective and clear teamwork in order to treat them properly. So that's the involvement of obstetricians, anaesthetists, and midwives to work around the patient. If there are severe circumstances, then it is really important to involve our multidisciplinary team at an early point to make sure the patient is treated holistically and all points are thought of. Often with a high blood pressure and severe hypertension, automated blood pressure monitoring systems can give us underestimated value. And so if we are querying the blood pressure at all, then it's always very good to cross-check with this being done manually. And we also must remember that these patients, when they're being treated in the postpartum phase, is that they are treated with oxytocin and not symptometrin. A symptometrin will cause vasoconstriction and arrhythmia and exacerbate their symptoms. Ladies with very severe hypertension, we will always manage in the high dependency unit of our labour wards. This is an area that is confined to them having one-to-one care, where they can have more equipment in order to monitor blood pressure, monitor heart rate and rhythm, and also a clear space where there can be a multidisciplinary team around this lady. We'd like to ensure that when they have very high blood pressure, they have 15-minute blood pressure checks when they are needing their blood pressure controlled. And then once we have control of their blood pressure, this can then be reduced to 30 and then 60-minute intervals. It's obviously very important for these very sick women that we have IV access, so at least 1 or 2 large bore cannula, so they are able to be treated very quickly. And some of our anaesthetic colleagues might insert an arterial line in the wrist, because this will then help us to have very accurate measurement of their blood pressure and also allows us to assist with treatment very quickly. It's important to look at the fluid balance. And so ladies need to be catheterized so we can monitor their urine output and have an accurate fluid balance. And I'll go on later to talk about why this is important and how this is a very clearly will reduce the morbidity for these patients. Obviously, once treatment has been started, they should be reviewed regularly by the multidisciplinary team, including the obstetricians and anaesthetists. And there should be a continuous CTG for fetal wellbeing monitoring. And so we can gain control before starting the process of delivering baby. All of our observations need to be documented on a maternity early warning system, which obviously shows trends of blood pressure, heart rate, respiratory rate, and fluid balance. And through looking at trends, we can see what medications patients are responding to and whether we are deteriorating or whether we are improving. And so having a modified version of this can be an invaluable tool in treating patients that are very unwell. So management. Obviously, the most important thing is to stabilise blood pressure, and this is the priority. And it should be treated immediately if the blood pressure is over 160 over 110. And I'll go on to talk about oral and IV treatments for this. We would then, because they have severe preeclampsia, we'd want to commence a magnesium sulfate infusion and go on to have strict fluid balance of these ladies only having 80 mils of fluid intake per hour, whether that is intravenously or orally. We need to have 6-hourly blood investigation workup, because the situation can change very quickly, as we all know in preeclampsia, with very quick deterioration, and the blood workup will assist with this. And obviously, once we're in a stable position, it is then becomes the need to deliver. It's always best to start with oral antihypertensives, and NICE recommendation is that labetalol is the first oral antihypertensive that is taken. And that would be given in a 200 or 400 milligram aliquot, and this can be repeated at hourly intervals. Nifedipine is our second choice, but often in many units across the UK, and it is at UHD at our unit, that we would use nifedipine as our first line oral antihypertensive, as it will not cause neonatal hypoglycemia like beta blockers can. There is a role for methyl dopa, but methyl dopa is not recommended in the acute situation and is certainly not recommended once the lady has delivered, as it can cause hallucination and postnatal depression. When we are giving labetalol in a practical manner, we would give a 200 milligram tablet followed by another 200 milligrams 30 to 60 minutes later if the blood pressure is not reducing. If this is not working, we would then move on to our second line, nifedipine. And we can use immediate release in smaller doses and modified release in larger doses. Nifedipine, as a calcium channel blocker and a peripheral vasodilator, has the capacity to reduce blood pressure very quickly. If we reduce blood pressure very quickly, this will obviously have a knock-on effect to the fetus. So we need to be careful with how much we are giving. If our oral antihypertensives are not working, and I would assume that they are not providing adequate control if we have given 4 doses of an oral antihypertensive, we would move on to our IV treatments, and that would be IV labetalol. That is given as a 50 milligram infusion, which is given over a 20-minute interval. And then once this loading dose of labetalol has been given, we move on to a continuous infusion where we would be giving anywhere between 10 to 100 milligrams per hour through this infusion. Many patients would be resistant to an IV beta blocker, and therefore our third line treatment would be IV hydralazine. I often find that when we are treating severe preeclampsia in a practical sense, magnesium sulfate should be started before IV antihypertensives, as magnesium sulfate does have the capacity to reduce blood pressure, as it is a smooth muscle relaxant, and reduce peripheral pressures. You may be able to control blood pressure just through starting IV magnesium, in which case it could then prevent you needing to run IV antihypertensive as well. Magnesium is so important in this scenario because, as well as controlling blood pressure, it will also provide neuroprotection for very preterm infants below 30 weeks gestation and reduce the risk of fetal brain hypoxia and the ongoing development of cerebral palsy. It has the effect to stop preeclamptic fits and is obviously our treatment for treating preeclampsia. Once magnesium sulfate has been started, we are then committing to delivering this baby. And it is used for 24 hours from starting and then continued for 24 hours after birth. When we're using magnesium sulfate, it needs to be given in a 4 grams over 5 minutes as an intravenous infusion. We then go on to give a continuous dose of magnesium sulfate at 1 gram per hour. If we need to use magnesium sulfate for the treatment of seizures, we can then give a further 2 grams through an IV bolus. And if eclampsia fits continues after giving this, we also need to think of an alternative diagnosis for fits, as obviously pregnant women can still present with many medical complications. When a lady is being placed on magnesium sulfate, it's very important to continue with observations so we can look for magnesium toxicity. Obviously, preeclampsia can cause a reduction in eGFR, and magnesium is renally excreted. Therefore, it is very easy to end in magnesium toxicity, and that will result in reduced respiratory rate and then subsequent manifestation from that. The observations that we would suggest is if we're oliguric with less than 30 mL an hour of urine being produced, there's hourly deep tendon reflexes performed at the patella with an hourly respiratory rate, and we send off blood to the laboratory to look for magnesium levels. Fluid balance. Fluid balance is extremely important in preeclampsia, and we should aim for a lady only having 80 mL of intake per hour, whether this is oral or intravenously. We mustn't preload our ladies with any IV fluids, as if women take on too much fluid, whether this is orally or intravenously, we can very easily lead into increased third space loss of fluid as the capillary basement membrane is very leaky. The third space loss then goes on to increase our risk of pulmonary edema, increase our risk of eclampsia, and increase our risk of worsening renal failure. And so by having very strict fluid balance, we will be able to prevent these very difficult to manage morbidities creeping in. So delivery, as Dr. Padma has mentioned, delivery of the fetus and placenta is the cure. We have to make sure that delivery is safe. So it is always best to make sure that blood pressure is controlled before we commence delivery. Depending on the gestation and the quickness in which you would like your delivery to be achieved, this can be done through an induction of labour or through delivery via caesarean section. Timing of delivery does need to be carefully balanced to manage prematurity risks of the fetus. And we'd always want to make sure that the lady and their fetus is in the right setting for their baby. If in the UK, infants that are born pre-28 weeks need to be in a level 3 neonatal unit environment to ensure that they can be managed adequately. And so we do need to think of our neonatal colleagues and have a discussion with them about how they would be able to manage the prematurity of that baby. We want to make sure that steroids can be administered so the fetus can have reduced risk of intracranial hemorrhage, ARDS, and necrotizing enterocolitis. And magnesium, as I've mentioned before, plays an important role in neuroprotection of the fetus to reduce the risk of HIE and further cerebral palsy. In the postpartum phase, we also need to carry on with our antihypertensives. And as Dr. Padma has said, antihypertensive need to continue for at least 2 weeks after delivery. We know that through postpartum physiology, that often in this situation, the third space loss of fluid will creep back into the intravascular space on day 5 to 7 in the postpartum phase. And so we can have rebound hypertension in this time. And so continuing with a regular oral antihypertensive is very important. We would use the antihypertensives that they have been taking in pregnancy, but if they are resistant, then as Dr. Padma said, enalapril can be a very good long-term ACE inhibitor to take if there is no renal involvement. It's important that in the postpartum time, that is 6 weeks postpartum, that blood pressure, blood investigation work and proteinuria has resolved. If it hasn't, further investigation will need to be done to look into why there is any further renal impairment. And obviously, we know that women that have experienced preeclampsia will have a higher instance of maternal hypertension in later life and ischemic heart disease. And so this is a very important opportunity to address lifestyle risk factors. And so that concludes my talk, and I would welcome any questions at this time.
Thank you. Thank you so much, Dr. Hafi, for your wonderful talk. First, I would like to thank the organizers, especially my dear Lakshmi ji, who have given me opportunity to chair the session. Lakshmi ji, I am audible?
Yeah, you are audible.
Okay. So, Manika, I say thanks to you. You have involved me in this wonderful webinar, and in future, I would like to continue along with you. I really feel very happy along with you. Thank you so much. The talk of Dr. Hafi was wonderful. She covered all aspects which is related to the pre-eclampsia or hypertensive disorder. She from how we can diagnose the case, like by blood pressure, systolic blood pressure, diastolic pressure, clinical presentation like visual disturbance, agitation, and the proteinuria increasing in quantity, as well as the blood changes in the form of thrombocytopenia, reduce in hemoglobin due to hemolysis, increase in ALT, creatinine, and even the changes in fetus in the form of Ctg. So she has explained everything very nicely, and even maternal complication, if we not able to control this high blood pressure in time, it can be so problematic, can cause intracranial hemorrhage in mother, DIC, eclampsia, HELLP syndrome. So as we know, the hypertension, especially eclampsia is, we don't know the exact cause. There are lots of theory, but definitely by timely management, we can reduce the complication. And she covers very nicely all aspects, and then she told about the nice guideline. Definitely nowadays we are using labetalol as a first drug of choice, even in our day-to-day practice in the severe hypertension, to bring the blood pressure down. But it's the very important thing is that the blood pressure should not bring up to that level in which the placental function may compromise and cause problem in the fetus. As we know that in hypertensive disorder, the placental function is already compromised. So we have to keep the blood pressure around 150 and 100 or 90 with the antihypertensive drugs. Nifedipine is a second choice. Methyl Dopa we don't use because of loss of side effects. Magnesium sulfate definitely is the treatment of eclampsia as well as the severe hypertension as a prophylactic to prevent the convulsions. And delivery she covered very well, especially when the baby is premature, should be covered with corticosteroid and neuroprotective magnesium sulfate to prevent cerebral palsy in the baby. And even these patients required management and proper watch in the postpartum period, because in the postpartum patient can develop convulsion and can persist as a case of hypertension. So we have to continue the antihypertensive drugs in postpartum period also. Nice job, Dr. Abi. You have covered all aspects. Thank you so much.
Thank you.
Any input from my co-chair, Dr. Sharma?
No, she had to go to another meeting, so she has logged out. Yeah.
Okay.
And Doctor,
can you permit me to?
Thank you so much, ma'am,
Can
for
you
joining
permit
us.
me, because
I think you are still at ISOPAB conference. We can hear the background voices, and Dr. Chandra is repeatedly saying, "Please mute, please mute." Actually, this voice is coming from ISOPAB.
I'm really sorry, because after that I have my talk here also.
No.
Thank you.
We are
Thank
very
you,
glad that you could log in and you gave your valuable comments. Thank you so much.
Ma'am, can I ask a doubt to Dr. Abi? Is it okay?
Yeah. So moving
ask a doubt.
Now, Charmila, first let's have panel discussion and then we can interact with them.
Okay.
Yeah.
So we are moving on. We have now our panel discussion that we are all waiting for. And for that, we have the moderator. I mean, it is for the first time that we have an international moderator here on the platform. And we have Dr. Fran Bernice. She's the senior registrar. She's ST7 trainee, Obs and Gynae from Princess Anne Hospital, University Hospital, Southampton. She is founder regional multi-specialty maternal medicine education evenings. So welcome, Dr. Fran, and we are all waiting to attend or to join to this panel discussion, where we have a wonderful galaxy of panelists. We have Dr. Pushpa here. We have Dr. Pushpa Jhungre. She has so many affiliations and awards, and she has popularized NDVH in Amravati. She was instrumental in establishing the first human milk bank in central India at Amravati. She has received Pudhakar Sanman Award and for her work in HIV positive patients, and Amravati District Best ICTC Award also she has bagged in 2014. Amog's Ratna Award for her efforts toward women health in India. So welcome, Dr. Pushpa ma'am, on this panel. Then we have Dr. Charmila. Dr. Charmila, most of us have known by now from the webinars that she has been a part of. Dr. Charmila is from Coimbatore Medical College and did her MD from GMC Mumbai. She was chairperson of the Clinical Research Committee FOGSI 2016-18, and she is a ICOG Governing Council member of presently. She is a national coordinator UNICEF FOGSI PCA and Medha FOGSI PG program. And she was past secretary of the Trichy Obs-Gynae Society. She is joint secretary of the Gestosis India Association and joint treasurer of IFS Tamil Nadu chapter. Then we have Dr. Arun Barwa sir, who is consultant Apollo Fertility Guwahati, Assam, who is also chairperson of the NE Northeast ESAR, Northeast IAG, president of the Dibrugarh Obs-Gynae Society, he senior vice president IMA Assam State Branch, and vice president East SOVSI. He is an active Rotarian for more than 25 years. Then we have Dr. Ritu Dargan, who is director Integra Specialty Clinics, Kamla, Nagpur. She is consultant Nelson Mother and Child Care Hospital, Nagpur, and she has done her PG diploma in medical legal systems from Symbiosis, Pune. She is also done her diploma in emergency obstetric care from Karolinska University, Sweden. She is ex-associate professor MG Mahatma Gandhi Medical College, Sevagram. And then we have very dynamic Dr. Priyankur Roy, who is consultant in fertility gynec endoscopy at the Roy Clinic and the Nova IVF Siliguri. He is national coordinator of the Public Awareness Committee, FOGSI. He is Indian representative, WATOG, FIGO, and joint secretary of the Gestosis India chapter. He has been past coordinator of the Perinatology Committee and the Infertility and Endocrinology Committee, FOGSI. He has published many articles and is a peer reviewer of Journal of Obs and Gynae India, has presented more than 50 articles in conferences. We can all see his so many awards, gold medals and the Korean award and things like that. So to cut it short, I hand it over to Dr. Fren for the wonderful discussion that we are all waiting for, and all the panelists who will make it so very interactive. Thank you, participants, for joining in great numbers. And I'm sure it is such a great topic that Dr. Lakshmi ma'am has chosen. And she's personally handpicked all the speakers, the national, international. So hats off to Lakshmi ma'am first, and then over to the panelists and the moderator.
Thank you very much. I feel very honoured to be asked to present some cases for this really quite very well renowned and very well respected panel. I've got 3 cases, so I'm just going to share the screen. What I think I might do is present the first case and then give a chance for the panel to discuss and to talk about that. And then before going on to the second and the third cases, because I think they might all bring out slightly different things for discussion, and I don't want the first one to get lost by doing the next 2. So let me just try to share my screen. Okay, now is that coming up as a slideshow?
Yes.
Perfect.
Fab. So we're going to case 1. So all 3 of these cases are primiparous women. This is our first case. She's a 32-year-old primip who has a high BMI of 40 at booking, with a family history of hypertension and a slightly high booking blood pressure. She's a non-smoker, she doesn't drink, and she's socially well supported without any particular risk factors. She's also rhesus negative. Now, some of her risk factors were picked up very quickly. So she was started on 150 milligrams of aspirin daily from the beginning, as soon as she was booked by her midwife at about 10 weeks. For the last few years in the UK, we have been doing free fetal DNA to check rhesus status in the babies. And so we found that the baby was rhesus positive. So she received anti-D appropriately at 28 weeks. She had a glucose tolerance test again at 28 weeks, which was negative. She was offered and declined COVID vaccination. I'm sure you have the same problem that we have, where we're offering COVID vaccinations and then we have many women who are choosing not to take them at the moment. Although her symphysis fundal height was just below the 97th centile, her weight gain on top of her BMI of 40 at booking meant that she was advised to deliver on the obstetric unit. She was seen just after term by her community midwife, where she had lovely normal blood pressure and no proteinuria, no other symptoms. So all in all, a relatively straightforward antenatal journey. So the following day, so just after seeing her midwife, she presented for a labour assessment and was found to have hypertension as soon as she arrived. She was examined very quickly as she seemed to be progressing in labour, and she was in active labour on arrival. At the hospital where she was delivering, they used nifedipine rather than labetalol as first line for acute management of her blood pressure. So she received instant release nifedipine and also had preeclampsia bloods and a PCR taken, as well as an IV cannula, and a Ctg started. Despite her nifedipine, her blood pressure stayed high, and so she was given labetalol. Still had a trace of protein, but nothing else, and was still 7 centimeters. I apologize for any noise in the background. So she was seen by a consultant that morning and was found to still have hypertension, but was contracting really rather too regularly, and so was given some terbutaline to try to control her contractions until we can get on top of her blood pressure, which we attempted to do with IV labetalol. She had an epidural sited before then progressing on with her labour following an ARM. We had to continue the IV labetalol throughout the day, and as you can see, her PCR was 26, so we were managing acute hypertension rather than treating her as a preeclamptic. She, after the start of oxytocin, became fully dilated quite quickly. In this trust, with an epidural on board, she waited an hour for passive descent before then starting to push. However, when she started her active second stage, she was found to have significant meconium, and so went on to have an assisted delivery. Gave oxytocin rather than symptometrin for the third stage, and as you can see, she's had quite an acute effect from her blood pressure and has had no impact at all on the baby's birth weight, which is quite a decent size for term plus 5. Baby had vitamin K and was breastfeeding. We continued the labetalol post-delivery at 80 milligrams per hour. That's what she'd required. However, a couple of hours later, she started to feel quite unwell, and so her IV labetalol was stopped before transfer up away from the HDU area out to the postnatal ward. She went home with an oxyparin and labetalol. With the plan, we have a plan for the community midwives who've been looking after them, see them for when they go home and see them on day 5 for blood spots, and then look after them up until about day 10 before they then go and see their GP. She also received anti-D prior to discharge. I'm going to stop sharing now. I'm going to pause share, and hopefully I can then see, everyone can see each other. I just went to stop share, resume share, stop share. I'm not sure if that's come back. So that's quite a common case that we might see of hypertension in labour. It's not that common that we need to use IV labetalol. I don't know if anybody from the panel has any comments or anything that they would do differently.
Can I ask something?
Of course.
The thing is, this patient had a BMI of 40. She was put on 15 kgs. Why was she allowed to go for a post-dated pregnancy? Why was she not induced earlier?
So we don't routinely reduce early if people have put on weight, if they've had a negative glucose tolerance test, and everything seems to be progressing well. We wouldn't normally induce people before dates.
But she was a chronic hypertensive. She had a 140/90 at booking.
She had 140/90 at booking, but then throughout her pregnancy, she'd had normal blood pressure and no proteinuria.
And when she came at 4:40 in the morning, she had a blood pressure of 152/90, which went on to 190/130. Why were the investigations not done at that point of time, and why antihypertensives and magnesium sulfate were not started?
So I think magnesium sulfate was not started because she had normal reflexes and normal clonus and no significant proteinuria. So she arrived at 4:40 and the bloods were taken at about 5 o'clock. So once she'd arrived in the hospital, it can take a few minutes for the midwife to get her into the room and for things to get sorted. Once the blood pressure had been recognized, she was moved so that she was going to be looked after by a midwife more used to looking after high risk women.
And for 3 hours, only nifedipine of 20 milligram has been given. Her blood pressures were not monitored, and at 7 centimeters, you could have done an ARM, which could have actually made the labor go fastly. Because she is already stuck on from almost 7 hours and 7 centimeters. That difference was too much, I think, and that was inviting trouble. The blood pressure shooting up, not controlled, magnesium sulfate not, because we don't see the reflexes for giving magnesium sulfate here. For us, a blood pressure of more than 160/110 warrants a magnesium sulfate.
Prophylactic, maybe a prophylactic use of magnesium sulfate.
And acute control of blood pressure. It will not be allowed to drag on with oral nifedipine or oral labetalol. Probably would have given her an intravenous labetalol, brought her BP down, because you see she has gone for hyperstimulation later on, and you've gone and given terbutaline and then put her on oxytocin again. I think that was not a right mate. Should have been ARM done, labor could have progressed.
Accelerated the labor.
And she could have delivered even without those high blood pressure shooting up later on. Because giving terbutaline in a person who's got preeclampsia is inviting trouble, I believe.
So do you routinely give magnesium sulfate as soon as you see a high blood pressure?
160/110, we give magnesium sulfate.
Prophylactically, we do if we find it significantly high.
And putting her in labor for 7 hours, a person who's obviously having such a severe hypertension, I think it was not the right thing. Should have delivered.
I think, Dr. Fran, I think maybe it's also because you have a lot of monitoring systems in place, which are not there in our country. We do not have that. So we have to rely a lot on maybe people who are not that well trained. So we tend to, be more liberal by using magnesium sulfate, because we can't risk having an eclampsia or an intrapartum eclampsia. So that is why we tend
our
to...
guidelines already recommend magnesium sulfate. So that is why we are all tuned to do that. And another point in this particular case is the electronic fetal monitoring was totally not taken into consideration. That's why the fetus has started developing certain amount of meconium stain, which may be relevant, may not be relevant, but that could have helped in acceleration of the labor depending upon the tracings of the fetus, which was also in distress due to this hypertensive episode.
No, I think fetal monitoring was done, sir, because they showed decelerations in late during labor. And as far as the meconium, I didn't think it had an impact on the fetus post-delivery. But yes, labor should have been accelerated. That is one thing I think we all would like to agree upon, that 7 centimeters from morning 5 a.m. till 8 p.m. in the night. By the time she delivered.
Unimaginable. I would have died in the middle.
I would have. You have to pitch in because you are working where you don't have so many monitoring systems. You all
exactly. No, but ma'am, even if you see by the definition of labor, even if you see the patograph, if you follow the patograph, they should have been an earlier intervention, because she's progressing slowly. She's not.
We consider that Indian babies, they mature earlier than the Western counterparts. So here we never allow the patient to become post-date. If she is having chronic hypertension, she is very much prone to develop hypertension, that is acceleration of hypertension during pregnancy. So we always see to it that she does not cross her EDD. So we induce. And after induction, she is intensely monitored. And whatever method we use for induction, we see to it that there should not be any hypertonus. So rarely we have this chance of giving or reason to give terbutaline in any patient. most of the times they respond to whatever method we are using for induction. And whenever the BP shoots up, that is, instead of giving nifedipine, we would have preferred IV labetalol, as Dr. Charmila has said, because then it is easier to monitor.
Titrate also.
Yes, titrate also if we are giving it in infusion form. And maybe when she was 7 centimeters dilated, we would have accelerated and delivered her within maybe 3 to 4 hours.
7 centimeters is a very happy moment for us, ma'am. Like you would have delivered her in the
comes
next
at 7 centimeters, we'll immediately do an ARM.
And I guess in this case, instead of using a partogram, I believe that they've used a labor care guide. So that is why I think they waited on for more than 12 hours, almost from 5 o'clock in the morning till almost 8 o'clock in the evening. So that's almost 15 hours. So I don't think with the partogram wait of 15 hours is definitely expected, and by no ways the alerted action line would allow that too. I think the new thing of the labor care guide, that is like no time duration for the first, second, or the third stage of labor is what I think they have. I mean, I'm not sorry, it's not the first stage. The second stage of labor is what I think they proceeded with. And the only thing I would, as Tamila ma'am has also said, I think labetalol oral was something, I don't know whether maybe you guys must be using it over there, but then IV labetalol would have made things much easier. And also using the tabitline when you said, I mean, of course, we had to do something at that point of time because he was prolonging at 7 centimeters for very long. So definitely ARM was something that was warranted. Maybe diagnose meconium a little earlier, so that could be one of the things that could have been done. But then all said and done, the baby and the mother was fine at the end of it. So I think it serves the pregnancy.
All's well that ends well.
Yeah, it can happen in the UK, but here if we leave a patient laboring from morning till night, the attenders also would have sat on our head there. Difficult to manage.
I think it proceeded because they had an epidural also, so maybe the lady had pain, but then with good monitoring, probably the pain was not felt much, and so probably the proceed was okay, I guess.
Maybe Dr. Barnes can impress upon ARM. When do we do ARM in such cases? And whether you, what is the guidelines at your centers about ARM? Because all of us are wanting to jump on to doing ARM here, as you saw.
Yeah. No, I agree. So I was surprised when I looked back through the labour care that had happened before I was involved in her care. I was surprised about why she'd not had an ARM at. So she came in and was examined at 4:40. I was surprised she'd not then had an examination and an ARM at about 8:40, 9 o'clock, when she'd had that second examination when she was 7 centimeters. So that would our normal practice would be examine after 4 hours. And actually, if they'd not made any progress at that point, we would normally have considered an ARM. I think the difficulty in this case is that we hadn't got on top of her blood pressure. And so there were concerns about her blood pressure overriding the fact that at the time the baby was quite content on the CTG, and so controlling her blood pressure and getting the IV labetalol started and getting her pain under control took precedence over an ARM. But I agree, I would also be handing the midwife an amnihook if she was coming out to tell me that the lady with very high blood pressure is still 7 centimeters.
Do we attribute her high BMI to this delay in the labor or increased duration of? Do we really attribute the high BMI to this? Or because in our country we do not allow so much of time, so under all close monitoring with this high BMI, this is a negative factor for labor. So how long you are going to allow in your country for that with all these infrastructures around you?
Padma, we can't hear you.
No, he wants to know, like a person who's got a high BMI, how long will you allow her to be in labor? Like, is it?
Yes, sorry. So Padma's trying to answer, but we can't hear her. So we would normally still use a normal partogram. We wouldn't alter a partogram for a high BMI. We have a lot of women at the moment with increasing BMIs, and so we manage them all in the same way.
Is the patient glued down to the bed, or patient was allowed to move here and about?
So we often will use an FSE in women who are very large in order to allow them to get up and off the bed, rather than being glued to the bed. We'd much rather they were up and mobile, as long as we can monitor their babies. We advise them to not go in the pool, because we have some women who choose to birth in the pool. So we advise them to not labour or deliver in the pool because of the complications of getting them out. And we normally advise them to deliver on the obstetric unit rather than with the midwives or at home.
At what dose of enoxaparin you use at what point of time and at what doses in this lady?
So after delivery, we would give it 6 hours after delivery or 6 hours after the removal of any regional anaesthesia. People have had an epidural cited after that. And we normally, we have a graduated increase in dosage depending on people's BMI and weight. So normally, if they're under about 90 kilograms, we give them 40 milligrams of enoxaparin daily, between about 90 and 120. That depends, each trust is slightly different. 90 and 120, we look at 60. And then if it's more than that, we're looking at twice daily doses. And then we use the RCAG guidelines to look at whether, how long, how many risk factors they have and how long they need to have it for.
Length of labor is not limited, as Fran says, because they have BMI and high BMI.
Padma, you are not audible.
Fran's baby also is participating in the panel today.
Yes, a very active participant.
Very active.
This chapter, this is called as reverse panel discussion, where panelists, they are asking questions to the moderator. I mean, really, seriously, we have done this in many webinars, and this is another way of conducting panel discussion.
No, because the way of treating this patient was slightly different from what
we routinely do.
And Dr. Fran said that they were bothered about the blood pressure of the patient compared to the delivery part. But the blood pressure also was not monitored adequately, and antihypertensives have not been given. 1 dose of labetalol and 1 dose of nifedipine, then allowing her to go to 190 by 130, and then the consultant sits in and starts on IV labetalol. I think that was not the proper method of care at all. Antihypertensives should have been given more aggressively and controlled. She did not bother about the delivery part or the hypertension part. That was a gross mistake there.
Dr. Fran would like to, first of all, thank you for allowing the panelists to ask you so many questions, which we normally do not get the opportunity to, because we are asked most of the time. And I would say, yeah, it's a definitely a little different way of management from what we do here. But then, of course, you followed your guidelines. We have done justice, I'm sure. So, Fran, I'd just like to ask you one thing. Do you guys allow birth attendants to be with this high-risk patients as well, or is it only with low-risk patients?
So the normal practice in the UK is that we have midwives who are mostly autonomous practitioners, and we have midwives who are more used to being community midwives and manage women in low risk units, and we also have a core of midwives who manage high risk women, and some of whom are much more used to managing very high risk women. So if she were to deliver normally, then it would normally be a midwife who maybe would deliver her. As soon as she requires an assisted delivery, then the obstetrician would be the person delivering the baby. But yes, if she had laboured quickly, she could easily have had a midwife delivering her. I'm actually going to move on to the next case, if that's okay. Which okay, so. So in this case, again, we have a 30-year-old woman in her first pregnancy. She has a normal BMI, and as you can see, she has a stable social situation and no significant risk factors either. She was seen regularly by her community midwife, and she was referred for growth scans, so she had quite a low SFH. The trust who were managing her antenatally used a personalised growth chart, and so as soon as they could see that she had a low SFH, she was referred in for scans which were normal. They had, as I'm sure we have in lots of trusts in the UK, and I'm sure there's an issue everywhere, we had a bit of a backlog with inductions, or they had a backlog with inductions, and so at term plus 13 for a post-dates induction, she was transferred to a neighbouring hospital who have reciprocal arrangements to try to reduce the risk of women going far too late, or for who need urgent inductions. On arrival, she was found to have hypertension and proteinuria, and was symptomatic of preeclampsia. She was given nifedipine. Her blood pressure, as you can see, was slightly high, but not at the point where you would all consider magnesium sulfate just yet. She had some prostin, which is what this trust used, as we were able to get her into labour. Her blood pressure did settle down a bit, slightly with the nifedipine, and she was reviewed about 2 hours after arrival by the consultant in charge of labour ward that day. She had normal bloods, came back an hour later, and she shrummed before going into labour spontaneously. The VE at 10 to midnight was about 4 centimetres, and she was requesting an epidural. Because of her diagnosis of preeclampsia, we asked for repeat bloods before the anaesthetist would be happy to put in regional anaesthesia. But before that happened, as a preeclamptic, and as we know how they behave, she delivered spontaneously. Not that long afterwards. This delivery was performed by a midwife as a normal delivery, and she was given oxytocin. She had probably for her a slightly smaller baby at term plus 13, but not significantly under what we would expect, and had vitamin K. Unfortunately, just after delivery, she had a significant separation bleed, requiring emergency buzzer and emergency alarm for PPH. And as you can see, we then needed to give her significantly more invasive management to control her bleeding. Placenta was delivered in the room by the registrar. However, it was felt that maybe there was some incomplete placenta, and that combined with her blood pressure still being very high, and the estimated blood loss of just under 2 litres, she went round to theatre. She had magnesium started and nifedipine given, and by manual whilst the GO happened, and then had what's relatively normal management of a obstetric hemorrhage in the UK, where she had the manual removal and then had a back balloon, an intrauterine balloon inserted, carrying on with an oxytocin infusion, carboprost, tranexamic acid, and some misoprostol. She had 2 units of red cells, and a second-degree tear that was repaired in theatre. Postnatally, she continued on the magnesium sulfate for 24 hours after delivery. She had a fluid restriction. She had Flotron boots whilst we were waiting to start her on enoxaparin, and 6-hour bloods until they started to improve. As you can see, her blood pressure improved, and she made a relatively uneventful postpartum recovery, although she has been referred for some perinatal mental health input, as she found, understandably, the whole scenario really quite traumatic. I'm going to stop my share again so that we can discuss what would have been done differently, and any questions or anything that the panel would like to discuss.
We wanted to differ on that post-induction, post-dated, that you agreed actually. And the other one was this patient had a preeclampsia because she had proteinuria along with hypertension, and magnesium sulfate, probably because her blood pressure was around 140/100, I think you avoided giving. But when you're inducing, I think it's better if you give an antihypertensive like labetalol compared to nifedipine, because nifedipine is known to be a uterine relaxant also. So giving labetalol would have made things much easier, but the luck was she had progressed, so that did not matter at the end of it. And that the placenta was probably removed by the midwife and not the consultant. Was that reason it went for a retained?
So the midwife attempted to remove it by controlled contraction, but was unable to remove it. And then because of the ongoing loss, once the registrar went into the room, the registrar removed the placenta, or the majority of the placenta.
It was under anesthesia, or it was not without anesthesia? Not with anesthesia.
The majority of the placenta was removed in the room without anesthesia, but then the blood loss was ongoing, and so there was a transfer to theatre.
Actually, the one thing that it should have been done by the consultant or the senior most person when there's a retained placenta in a person who's already a preeclamptic, because preeclampsia with PPH is a dangerous thing to manage, because you cannot give your bloods as you can give in a normotensive patient. So probably the first time when she had a retained placenta, she should have been taken in the theater and removed by a consultant so that there was no retained placenta. The bits remaining there, which was causing the second episode of PPH, which was like managed better, but 2500 ml managed 2 red cells, two points. I think that will not be so easy in our country, managing 2500 ml loss with just 2 units of blood.
Yes. So I think the period between the removal of the placenta by the registrar and then the transfer to theatre, that was quite a short period of time. It wasn't. I don't think they left the room between those periods. I think they attempted to remove it in the room, realised that the blood loss was ongoing, and then went to theatre.
I think the case was quite well managed, Dr. Pranda. I think it was quite well managed. I don't think, I don't see many lacunae in the management as far as concerned. And this is a nightmare that all of us do anticipate with preeclampsia. So we do know that this can happen to anyone. But I think she was quite well managed. I just wanted to know, do you routinely give enoxaparin to all patients on discharge, or is it only to preeclamptics?
So we look at their risk factors. So we don't routinely give it to everybody on discharge. For her, the preeclampsia, and the EUA, with the significant blood loss, would have put her into requiring enoxaparin on discharge. Okay. So we add in other risks. Apart from that, she didn't have any other significant risk factors. She had a normal BMI. She hadn't had a prolonged labour. She'd not had an instrumental delivery or any family history, which are some of the things that we also look for.
Dr. Ritu, here also we give many patients of us, obstetric patients, enoxaparin now.
No, I do. I do give, but I was just because both the patients received enoxaparin, but not all. I don't routinely give it to all patients. That's what I just wanted to know, because a lot of RCOG guidelines, I think post cesarean you do give it to all patients. I think because RCOG guideline does recommend that post cesarean it has to be given to everybody. So that is something we don't follow. I don't think we are following that. Unless the patient is obesity, yes, but not routinely a lean thing, because early mobilization is also there, but you routinely give it to all post-cesarean sections?
No, see, the lifestyle of our people have changed, Dr. Ritu, now, so they do not move at all. That's what I see. From pregnancy till delivery, they don't move at all. After delivery also, they don't move at all. It's better you err on the safer side.
Charmila, they do move. Even
it is up to us.
You are talking of some VIP, very, very VIP patients, but routine patients, they do.
They are up and about. They are up and about in say 8 to 10 hours.
Yeah, they want to get up and.
It is up to us to advise them on the ambulation.
Yes.
If we are the managing obstetrician, it is for us to tell them.
Yes.
That they should ambulate, mobilize as early as possible.
So I think if they are, if it's only an elective cesarean and they don't have any other risk factors, depends on the hospital whether or not they get enoxaparin. But if they're having an emergency, there's often other reasons or other risk factors which require them to then end up with kind of a 2 or more risk factors requiring enoxaparin to go home.
That in India, the guidelines are being followed, and the guidelines we try to rope in is from different countries, like American guidelines, European guidelines, Royal College, and who suits our patient, we like to bring in them for our individual patient. That's the biggest problem we have. And unless the cases goes perfectly well, we keep quiet. And whenever there's a problem, we try to insight ourselves which guideline was wrong in our practice. That's the biggest issue with us.
I agree, sir. I completely agree with you.
ICOG is coming out with guidelines, so just wait, and we will have our own Indian guidelines very shortly.
When you will be the CRI, we are really looking for the guidelines, because we also want that everyone in our country must have our own guidelines.
We have a standardized.
Because our practice and our patients, they definitely differ from what Fran is handling. So they have totally different set of patients with their RCOG guidelines. We have totally different set of patients, and we have so much limitation as far as our infrastructure, our monitoring, our cost factor is concerned, because our patients are paying from their pocket. So as a clinician, we have to be very, very alert and conscious about the budget part also. So yeah, we do have our limitations, and with those limitations keeping in mind, we will come up with our Indian guidelines very soon.
Looking forward.
That will be great, ma'am.
Dr. Florin, just wanted to ask you one thing regarding this case. Of course, very well managed, and it was taken very well. But just one thing I would like to ask. I see on like post delivery when you started Maxel for her when the EUA was planned, she was also getting nifedipine. So do you give Maxel and nifedipine together, and is it justified in giving it, or is it a contradictory thing which you should not ideally be giving together?
So they can be used together. I'm probably more likely to use labetalol with Magself, so that we can then go on to, if we're managing a very high blood pressure, we may need to give IV labetalol as well as that. I think the magnesium and the nifedipine was used because it was available more quickly.
I think Maxel and labetalol would be something which I preferred here, but then yeah, okay. Since its availability is more, so maybe you'd have packed it, yeah. Good. Otherwise, very well managed.
Yeah, the problem then with labetalol is that you end up with a midwife trying to look after a magnesium infusion and a labetalol infusion and potentially a postpartum oxytocin infusion and doing the fluid balance. That's a lot quite heavy nursing, which you may then require. But you've got several people that might need to help with that. So our third case is not such a happy case. But we'll see where we get to it. Where maybe there's a kind of ongoing investigations into it, so it'd be interesting to hear a point from somewhere else, but we'll show you our third case. So this again is a woman in her 30s in her first pregnancy. She has a BMI of 35. She's a non-smoker with no social concerns. She does have moderate asthma, for which she takes an inhaler occasionally, and she's rhesus negative. So she saw the consultant for her BMI. She started on aspirin and had serial growth scans. She had anti-D given at 28 weeks because, again, she's carrying a rhesus positive baby. I'm assuming that she had a GTT. There's no particular note of it anywhere. And at 32 weeks, she was seen in day assessment with slightly raised blood pressure, but no proteinuria. So we have a setup where women can self-refer or be referred by their community midwife or referred by their GP or A&E to come into day assessment to be seen by the midwifery team there and to be seen by the on-call obstetricians if required. So she came in, she had some blood pressure monitoring, went home again. And again, she was seen at 36+4 after her growth scan, where she had slightly high blood pressure again on arrival, which settled, but no proteinuria, and so was started on home BP monitoring. Blood pressure was high at home the next day, and she had some symptoms of preeclampsia, and so she came in again to be seen by the day assessment unit. She was reviewed and started on nifedipine before being discharged home again. We may come back to that in a minute. The following morning, she phoned labour ward to say that she had some severe abdominal pain and vomiting, and possible right upper quadrant pain. The midwife who took the phone call was concerned about how painful everything sounded and called an ambulance for her. She was seen not that long afterwards on labour ward. Her blood pressure was slightly high, slightly elevated, but not shockingly so. And there was initial thoughts that maybe she had a diarrheal illness, which would be explaining her pain, but the Ctg didn't meet criteria when she was triaged. It was recommenced shortly before 9 o'clock and was seen by the registrar due to poor variability. She had some fluids and some bloods taken, and then had another bag of fluid at 10 to 10 before being given some nifedipine. I've spelled ondansetron wrong, sorry. The Ctg continued to be concerning, and so there was a decision made at 10:40 for a category 2 cesarean. She went round to the theatre, having had a listen in on the ward. Unfortunately, when she got into theatre, the midwife in charge of her care was unable to hear a fetal heart, and a scan undertaken by the registrar also showed no fetal heart movements. About 10 minutes later, there was the consultant present, and then a second consultant shortly afterwards to confirm that unfortunately there had been an intrauterine fetal death. The cesarean section was not performed, and she was transferred to recovery before starting on some analgesia because of her ongoing pain. There was a discussion and a plan made between the two consultants present, as well as the anaesthetic team, to start an induction of labour process, give her some HDU care, and take repeat bloods, including clotting. Once she had some nifedipine and her bloods came back, she was given an epidural and had some misoprostol before an arterial line was sited. We've got the availability, the capacity in the HDU parts of the labour wards to start people on arterial lines, and our midwives are trained. The HDU midwives are trained in order to look after arterial lines, so that we can monitor blood pressure much more invasively. She was felt later on that afternoon to be having severe preeclampsia with falling platelets, and started on magnesium sulfate and a fluid restriction in urine monitoring. And again, unsurprisingly for preeclampsia, she progressed very quickly in labour, and preparations were made for delivery with the consideration for a postpartum hemorrhage. She had a vaginal delivery of a stillborn baby girl about 2 hours after becoming fully dilated. It took quite a long time for her placenta to deliver. I think that might be slightly wrong timing. It took some time for her placenta to be delivered. I think that should say 2050 rather than 0150. I'm sorry, I think I put the wrong number there. 0150. So about half an hour, so her placenta was delivered, and she had a postpartum hemorrhage of a litre at this point, despite active management. Postpartum, she had ongoing bleeding, and again, she had a plan for examination under anaesthetic with 2 units of packed red cells, and a Bacri balloon and a vaginal pack, which we used to keep the Bacri balloon in place because some of them have a tendency to slip down out of the uterus. We have the facility to take a ROTEM, which was taken in theatre to look for whether or not she was going into DIC. She had low fibrinogen at that point. However, we didn't give her any further blood products then, which may have made her slightly better, and she still continued to have falling platelets and a raised creatinine for some time after that. She recovered slowly with HDU care before going down to our bereavement suite once she was stable enough to be cared for by our specialist bereavement midwives out of the way of the normal labour ward. I'm going to stop sharing now. This case is going through some investigation still, because we know that there are some things that we could have done better with it, but it'll be we felt it was a good case to share about kind of the dangers of preeclampsia and the effect that it can have on the woman and their family.
I would like to tell how differently we would have managed this patient.
Please do, please do.
Whenever hypertension is diagnosed, we don't give OPD treatment. We admit the patients and then continue monitoring with all the investigations, including that for fetal well-being. If we had suspected that the baby size was large, as later it was said that there was shoulder dystocia, if the baby size was large and she continued to have hypertension, we would have taken her for elective cesarean section. Or if the baby size was adequate or the average, then we would have induced her, looking at her rising blood pressure and then appearance of proteinuria later on. So we would have induced her. Even if she was managed on the similar lines, then whenever the variation were noticed, at the first instance, we would have taken her for intervention, that is by cesarean section, we would have delivered her. And of course, with At the time of cesarean section, there are many more people to monitor the patient. So this postpartum hemorrhage would have been prevented.
Can you hear me?
Yeah,
Yes.
yes, yes.
Yeah. Okay. I mean, I was involved in the later part, just after delivery, because I came on as the on-call consultant. So I have a little bit more detail than Fran. Is that the shoulder dystocia was not because of the size of the baby. We often find it after IUD because the baby lacks tone and the shoulder can be, stuck. But it has no implications to the baby at least. And the mother didn't have any tears. I think she had just a minor first degree vaginal tear. So it wasn't due to the size of the baby. And secondly, elective cesarean section rate is comparatively low compared to India. Our rates locally are about 25%. It is because we don't just section, because we have a round-the-clock monitoring. And going back to the previous case, you asked why did the registrar remove the placenta and not the consultant? Now, Fran has had 7 years of postgraduate training, and our consultant, because I have trained in India, is 3 years of MD and you become a consultant. So we have 2-tier system of an ST3 plus, which is post MD, and Fran, who is more than a junior consultant. So there are 2 people. So just because they are called registrars do not mean that they don't have the experience. So the placenta by cord traction, it wasn't manual removal of placenta. So the registrar tried to remove it by control cord traction. When it didn't happen, they have been taken to the theater where the senior registrar did the manual removal. That is the previous case. But what I'm saying is basically the thresholds for induction are higher. So we don't induce just because they have BMI. We have strict criteria, because otherwise we will be ending up inducing a lot of people and we don't have the staffing. And obviously NHS is free. And, we have to distribute the resources to the most sick people. And at the same time, the outcomes are quite good. So I would say, so this patient, unfortunately, the CTG showed we have what is called as a computerized Ctg. So the computerized Ctgs in the antenatal period, when they're not in labor, it can actually pick up on metabolic acidosis going on in the baby. So the CTG triggered the criteria. Computer tells you that there are some problems with certain beat-to-beat variability, which could be indicative of metabolic acidosis. And therefore, that was the reason for deciding on the cesarean section, not just the blood pressure, because we need to control the blood pressure. General anesthetics are not given without controlling the blood pressure, because they can have CVA, high blood pressures. General anesthetic intubation, we know, can cause strokes. So we tend to be a little bit more careful rather than jump and just do C-sections.
Here also we don't jump. Dr. Padma, we don't jump to do cesarean section. You may think that the incidence of cesarean section is definitely lower at UK as compared to in our country, India. But definitely in such a patient, we don't give home management. Maybe because there are gadgets lacking with the patients. That is one thing. And if she is hospitalized, we are able to manage, and more important, we are able to intervene in time.
So practices differ, I agree.
Yes.
I feel she should have been induced when patient first complained of right upper quadrant pain and she had her urine and then she was sent home. I feel she should have been in hospital. That is one thing that, yes, I agree with Madam. She should have been in the hospital and not have been sent home, because I think it's very unfortunate that she lost the baby despite your computerized CTG, whatever it said, but it was too late for it to actually detect her. By the time you took her, hardly it was minutes, I think, before you took her up and when the heart rate disappeared.
Yeah.
So it's very unfortunate, but maybe had we jumped in a bit earlier, we could have saved the baby also.
Yeah.
Sharmila, I am silent. Your comments. Because here, Fran and Padma, we are having east, west, north, south of India. Huh? And every region also has got different set of patients and different kind of practice. Some are in private practice, some are in the government services. So everywhere the logistics and the things differ. Yes,
We
Charmila,
in fact have chosen a very good panel.
Madam,
that is why, I mean, everybody is having different
We
opinions.
are working in different setups. To be frank, we are working in different setups.
Yes, yes. You all are working in different setups with different logistics. Yeah, Charmila?
At 32 weeks, she has been diagnosed with hypertension. Investigation reports are not available to know like whether she has got any other organ development at that point of time. Just proteinuria alone is not going to tell you like whether any organ is involved. Probably an investigation should have been done at that point because she has developed right upper quadrant pain and she's gone for falling platelets. That means she has been developing a HELP syndrome and that was left without being managed. And a person at 36 weeks who has come with a right upper quadrant pain, sending her home, I think will be criminal. We will not do it in our country. She will be admitted and she'll be delivered. Jumping for an induction or a cesarean is not a thing here. She will be delivered because we know that she's going to for complications. She's lost her baby. She needed blood transfusions and component therapy, which are all unnecessary to have been done at that point of time. And
so I can answer you that. I can answer you that. The blood tests have been done. It's just that Fran works at a different hospital now, and we have provided her the summary, and we didn't put all the investigations in there. And Abby is raising her hand because Abby and myself, we work in the same hospital where this patient delivered. And Fran works in a different hospital, and we provided her the summary. And we didn't put in all the investigation. This patient definitely had, when she came to ANDA, and Abby will tell you, ANDA lead, we always do baseline blood tests and they were normal, and it's not uncommon for HELP to develop later on. Symptoms may be earlier.
These patients are very unpredictable. You know, they deteriorate within a matter of days, or they may take weeks to deteriorate.
Yeah, so she was assessed in ANDA, and you made the summary. Just tell us about, the result.
Yeah, so I mean, as Fran has alluded to, this case is under investigation because there are differences in care that need to be addressed. In our Antenatal Day Assessment area, we, when ladies present with hypertension, they do have a full workup investigations of full blood count, urea creatinine ratios, and liver enzyme tests. And so they're not allowed to go home until everything has been proved to be normal. And that was the case when she was 32 weeks. She did go home on our Shear system that Padma presented earlier, monitoring blood pressure and proteinuria in the home situation. And I think the first episode where the ball was dropped for this lady, unfortunately, is when she presented at 36 plus 5 days with new proteinuria. She should have been admitted in hospital at that point. I think, unfortunately, when she presented overnight with the diarrhea and abdominal pain, this was a real red herring. It was assumed that all of her symptoms were because of a sort of a diarrhea and vomiting norovirus type picture. And unfortunately, that detracted from her mild symptoms. And she really did have mild symptoms of preeclampsia, but obviously did have deranging blood tests. And so I think it's a good case to highlight that actually, huge morbidity can happen if we don't follow our guidelines and if we don't, act swiftly. And I think, very sadly for this couple and their family, things weren't acted upon quickly enough. But we will be obviously conducting investigation and remedying what has gone wrong.
Like in a gestational hypertensive, how often will you do her labs? Like, what is your frequency of monitoring when she's a gestational hypertension, as in this patient at 32 weeks?
So if they're gestational hypertension with no proteinuria, normal blood tests on their first investigation, we wouldn't repeat their labs until they have new proteinuria or their blood pressure rises.
But your guideline says you repeat it every weekly.
It depends upon if they have proteinuria, and it depends on their PET ratio testing. So if they're in a moderate group where their PET ratio is up to 80, then they would go into a stream where they have weekly testing.
That seems a little different.
In this particular patient, the GTT was said to be query. What exactly we mean by query GTT?
Fran didn't have the information as to whether that GTT had been performed or not. And so I think that's why it was the question mark in her presentation. But the lady's BMI was below 35 and she had no other risk factors for diabetes in pregnancy. And so whether she had the GTT or not is probably irrelevant to what's happened.
A BMI of 35 is a high risk factor for GDM actually. 35
Yes,
is
so if
quite
they have
high.
if they have a BMI of 30, that would initiate them having a GTT.
Asian average is 18 to 24 for us. So 35 is quite high for us.
So if patients are of an Indian ethnicity or Afro-Caribbean ethnicity, etc., that would be a tick for having a GTT. But if they're Caucasian, British, then it would be on a BMI of 30.
For us, she's a very high risk patient, sir. Arun sir, primary, 33 years old, and a BMI of 35. I would have been like so careful with her. Because here our practice is different because we see our patients, we manage them in the labor room. We are the midwives, we are the registrars, we are the consultants. So we do everything from 1 to 100 is by us.
We are all in one. And we are available 24 hours.
24 hours, seven days in a week, 365 days.
And actually, it was a wonderful, wonderful discussion, Dr. Fran. You took up such beautiful and different cases.
Yes.
And actually, in the chat box, we have a very senior doctor, Dr. Jayam Khanan, ma'am. And she's written that in India, fetal loss is something where the lawyer will drag us to court and all that. So here also we have to work under, as Dr. Chamila said, we are from 1 to 100. We have to do each and everything, right from being your junior resident to a registrar to a consultant. You have to take the responsibility right from the OPD till the delivery until maybe 6 weeks postpartum. So we have to be very, very careful, and with the limited resources that we have, and with the sword of medico-legal thing hanging on our necks, so we are not that very tolerant on. And the induction of labor, as Dr. I think Padma was saying, you are not very. The threshold is lesser there. We don't have a very low threshold for inductions. We do good. As soon as we get any indication, we go in for active management in all the cases. And those cesarean rates, we have a little higher cesareans, but we have our guidelines in place, and we are limiting the cesarean section rates at every stage. We have to even report to our authorities how many cesareans we did, how many normal deliveries we did in a month, and how many of them were, what all birth weights were there. So we have extensive data that we have to submit to the government as well. So it was, I think, a wonderful experience, Dr. Lakshmi ma'am, with the panelists asking the questions from the moderator, and with the variety of cases that we had. It was, I think, an excellent sort of a presentation today that we all had. And I think it's already 6:15.
Jyoti, just a minute. Jyoti, our cesarean sections might be on a higher side because so many patients, they reach to our tertiary center at the last moment with a very, very gross emergency because of the lack of infrastructure. Whatever they are facing, they don't reach in time. Many people, they do try deliveries at home. So, there are so many different issues with the practice in India that we really can't compare our practice with the UK practice. It is totally different. But yes, Fran has brought out all the various points of discussion, how we differ from West. So that is a good point, and we all should have our differences of opinions so that we know what is going on which part of the world. So Fran, thank you very much. And you have really brought out 3 different kind of cases, and it was a very good deliberations where East met with the West with the differences of opinion. So it was too good. Thank you so much. And now I invite Padma, our international convener, for her closing remarks. Padma, unmute yourself. Yeah.
Thank you. Thank you very much for this opportunity, and thank you also for your patient listening and being very interactive and actually questioning us. And I have to say that we had to actually struggle to get cases because these are the worst cases we have selected. So as you can see from our maternal mortality record in the UK, I'm trying to defend the stillbirth rates. They're quite small compared to UK. So we really had to go to the databases to get the worst cases. So that is not what our standard of care is. And obviously these cases will be discussed. We have discussion panels. So anyway, so thank you for being very interactive and asking questions and sharing the experience, because I worked in India and I understand, because I used to work as a postgraduate doctor. So I know the lack of facilities, and therefore you are more forced to intervene earlier in order to prevent, stillbirths or maternal deaths. Whereas we have the support system, and it's mostly midwifery-led care. And but thank you so much for this opportunity. I thank my co-speakers, Abby and Fran, for doing such a good job. And thank you for being such a good audience.
Thank you. Thank you, Padma, Abby, Fran, all my esteemed national faculties and dear audience. Thank you so much for your active participation and dedications.
Thank you, ma'am.
Thank you, ma'am. Thank you for the opportunity. Thank you. Thank you, Dr. Lakshmi.
Thank you, and thank you, Team Walter Bushnell, for providing us with the technical support.
Thank you, ma'am. May I end the session?
Yeah, Vishal.
Thank you, ma'am. Thank you, everyone, and we look forward for such a webinar in future also, ma'am. Thank you, everyone.
Thank you.
Thank you.
Thank you. Thank you so much.
Dr. Padma.
But what is most important is what is best for our patient must be offered. That's the most important thing. Opinions will differ from even individuals within the country.
Yes, yes. Even in India, everyone will differ how they are going to manage that particular case.
What is best for our patient must be offered.
Yeah. At that particular point of time, Arun. Yeah.
It's very easy to put our words at the end of the case, but while handling the case, how you work, which brain you are in, and what facilities you are being surrounded are all taken into consideration.
And we have to consider cost, and there are so many factors which we in India have to consider. Chalo, okay.
So your guidelines will be very important for us.
Yes, Padma, unmute yourself. Vishal, you can stop the recording.
Thank you. Thank you so much. And
welcome.
Yeah. Thank you, Lakshmi, and the conveners are the conveners. Yeah.
Yeah. Thank you. We did miss Jyotsna here. Chalo. Bye.
Bye. Bye.
Bye-bye.